Kwa sababu computer, if you get disconnected for the session stops recording.
It's fine. So it's recording.
So once to stop sharing.
Yes, so that you can. So yes. So we'll stop sharing. Stop share.
Stop sharing. Control.
So that's what they only see. Yes. So that's their thing.
Unaona kitu? Inaitwa gimbal.
Gimbal.
Oh, haya.
Unaweka simu yako hapa. Na control na hizi. Unaweza zungusha hii pole pole, unaweza zungusha hivi.
Haya.
Unaweza record. Lakini tu ni accessory. So hii ukapata kama unaweza kwa mbele sana. Unajua hii hata ukisheki kuna nini shock absorber. Video yako itashake.
Oh,
Okay. So now, are you going to rename your? Can you rename your?
Yeah.
So can you rename?
Ndio nauliza kuna vile to here. But lazima iwe pale.
Ili duplicate.
Hii ni extended na tunataka iwe extended si duplicate. But ile control ya zoom ikiwe hapa. You unasema like tuseme you want to unshare. Tuseme you want to stop sharing. Naona lazima tena upeleke kasa huko uangalie huko.
Lazima stop share down. Then what do you want? Rename George.
Unaweza ita research.
Rename George. Calling post.
Nasikiliza pale kwa
you can just call it
hapo tu. Hapo tu
wanted to change hapo.
Post.
Hii machine unaweza utakuwa na control. Inafaa kutoa host. Ile itakuwa kama
ndio nilikuwa nasema juu huwezi kuja huwezi ati kuangalia nini. But unajua
ama presenter peke yake. Without anything. Host inamaanisha because unajua akiwa host hapa kama akiwa host anaweza mahali kuna presenter atakuja vipi? Akiliki mahali
it is correct.
So that's why someone will have the presenters who are present. Ile iko we are spread. Kama jaji unaona what we do, we don't allow presenters. Once we just tell them what to do, just tapping.
So hii umesema
Call yourself host. Just write host. Then okay. So you're saying he transfers the rights to you. But how about you? Transfer full rights to them. Transfer full rights to them. Yeah. Then
Hebu niambie ni gani hiyo?
yeah, please. Now, if we give the host name stop project. No, okay, stop.
As long as when the panelists, you can share the screen.
Then we'll control things from there.
So mimi ni
Well, you asked to normal.
Oh. Normal panel.
So, so then you ask the presenter who does the provision for video. What is that?
Yes, you want to make camera.
They just need to
The present-
their slides. The presenter
Ah,
slides.
oh,
It's about the camera. You see the person. So when you present, mainly worry about seeing your face
or whatever you present.
So whatever.
Actually, ile tu ile mtu ataonekana, ile mwenye anasimama hapa kuingia bila present.
Yes.
Hiyo video yake ile inaonekana hapa na watu wengine.
So itakuwa inabidi mtu anakuja hapa. Yes. So what you do is you make sure the chairs and then the presenters. Unajua kuna idea hizi kufanya wapi? Unaona machine maandiko. Unaweka wireless mouse. Ile keyboard. Unaona kusema hapo sasa use the wireless. Control it hapo watu wengi. But now imeingia too late. Sawa move on. Serious, wacha nikwambie. Nimekuwa na ile na niwe mtech. Vitu tatu na then normal code. This is a
Mlango na hizo dirisha.
Good evening, everyone. I'm glad that a good number of us have managed to make it to this session. And I take the pleasure of welcoming you to Aga Khan University for a Researchers Symposium. Before I say anything else, I need to acknowledge the presence of the two deans, the Dean of School of Nursing and Midwifery, University Rango, and Dr. Lukoya Atwoli, the Dean of Medical College, Khan University, and in the audience. Also, I need to acknowledge the presence of the founding Dean of the Medical College at Khan University here, Professor Bob Armstrong. I know it's early in the morning where you are, and we are delighted that you've been able to join us. I would also like to acknowledge the presence of some of the judges, of the judges in this session. and the keynote speakers. We have a keynote speaker for today and another keynote speaker for tomorrow evening. And last but not least, all the participants who have managed to join us here. I should also not forget to acknowledge the 24-member organizing committee that has done a tremendous job in getting us to where we are. It's only been a few months when the committee started working on this program. We are not sure that this year we would actually be able to hold this symposium, but within a very short time, the committee managed to do that by holding weekly meetings. The organization of the program, as you may have seen from the material which has been sent to participants, is that we had a poster session early this morning between 8 and 9, which each of the presenters had 5 minutes, and then there was a question and answer session at the end, and that went pretty well, not without a few hitches, ICT hitches. And we believe that we learned from the morning session to make these evening sessions more favorable and enjoyable to you. So the lessons from morning have been brought down to this evening. So I hope we won't have as much negative experiences. This year, like every other year, we also be giving some generous awards for both the oral and the scientific, for both oral and the poster sessions. And the hallmark of this year's symposium is going to me, as far as I'm concerned, is actually the panel discussion, which is going to be taking place as the last session tomorrow evening. I have a pleasure in announcing that the provost has actually reorganized his schedules so that he can be able to grace that session. So I look forward to having all of you in that session tomorrow. So without much ado, I will now take this opportunity to ask Dean Lukoye to say to make a few remarks, after which then the Dean School of Nursing, Nursing and Midwifery, Dr. Eunice Dirangu, you make a few remarks too. So Dean Lukoye, then Dean Dirangu.
Thank you very much, William. I am currently just leaving another function where I was attending the launch of the Jamhuri High School Alumni Association. Therefore, I'm at a place where you're not going to see my face, but you can hear my voice. And I think what I wanted to say today is that this symposium comes at an interesting time. And in fact, my current circumstances frame the symposium very, very accurately. At the beginning of this year, nobody would have predicted that we would be having a symposium in which the majority of the people attending are not in the same venue, in the same room. But today, this is what we are experiencing. Indeed, many people attending this symposium might not have attended this symposium if the year had proceeded as expected, because people would have been making plans to do all sorts of things, and they would never have thought that they would have an opportunity to attend an enlightening symposium such as this one, even if they're not in the same physical location. And therefore, while COVID-19 has presented to us significant challenges this year, it has also presented us with opportunities to innovate, opportunities to do things differently, and opportunities to demonstrate our ability to rise up in the midst of difficulties. My expectation from this symposium is that our young early career researchers will have an opportunity to showcase the work that they have done to a wider audience than they would have had under normal circumstances. My expectation also is that they will demonstrate innovations that perhaps they would not have thought about 1 year earlier. And at the end of the day, we will demonstrate that no matter what happens, no matter what calamity we face, we are set up in a way that we are able to generate solutions and look forward, learn lessons, so that when something similar happens in future, we will be even more prepared to deal with it. So I thank William and the team that has organized this symposium. I thank all the participants who have logged in and those who are going to make presentations. And I wish you very fruitful deliberations during this symposium. Thank you very much.
Thank you very much, Professor Toli. We are sorry that we had to overly inconvenience you by getting you from another function that you actually have to do this on your way to your next destination. But thank you very much for being available to grace this occasion. May I now call upon Professor Tirango to come and make her remarks.
So good evening, everybody, wherever you're tuned in from. It is such a pleasure for me to be here today. I think this being the fourth early researcher symposium, we've definitely come a long way. For 2020, any event we have that actually comes to fruition just really demonstrates the ability of all of us to really create, but also to problem solve and to innovate. And for this event in particular, I think it provides a good avenue to start building a critical mass of young researchers, because we keep saying that for this part of the world, we still don't have enough evidence around the practice that we're doing, the clinical, the community, and the people we serve. And I'm so hopeful that during this symposium, in addition to listening to all the amazing research work that has been done, the two keynote speakers, they are young researchers for whom others can emulate and get motivated by. So that as we go along, we are able to start to see that it's not only a few people who are engaging in research, but research becomes part of what we do as academicians, but also as practitioners. The other thing I'd like to talk about is the idea that for now, when we look at how much evidence we are starting to generate around COVID, this for me is a starting point that even post-COVID, we'll continue with that sort of engagement around research that is looking at factors that have affected us, especially after going through this pandemic. So throughout this symposium, I hope we'll all be able to network. I'm hoping that through this symposium, new linkages, new connections will be built, and that at the end of it all, we'll see more research happening, particularly research that is collaborative and interdisciplinary. With those few remarks, just to say thank you to everyone, and we look forward to learning on together, and all the best, and I hope we all enjoy the 2 days. Thank you.
Thank you very much, Dr. Tirango, for those opening remarks. And now we have got the green light to delve into the scientific program. And to start us off is Professor Rod Adams, who is going to be the chair of the first session. So welcome, Professor Adam. He is based in the Department of Pathology at Aga Khan University. So welcome.
Thank you very much, and welcome to all of those of you who are attending, and welcome to the speakers who are coming up now. And this will be interesting because we have a chance to hear about COVID and some of the things that we don't normally hear about in terms of the clinical care, because these are some of the other fallout effects. The first speaker is Dr. Jasmine Shaw, who's here at Aga Khan University. He's going to be talking about mental health disorders in healthcare workers at Aga Khan during the COVID pandemic here in Kenya. So welcome, Jasmine. I will hold up my hand at 9 minutes so that we can really endeavor to stay on track.
Good evening, everyone. Today I'm here to present a very interesting and undervalued topic, which is mental health disorders in healthcare workers at the Aga Khan University during the coronavirus pandemic in Kenya. Little did we know that 2020 is going to be a historic year. COVID-19 is a newly global catastrophe that is beyond the scientific postulations that begin with the epidemiological models, the social imaginations, and the philosophical insights. This pandemic, a public health emergency announced by the WHO during and declared a pandemic that was emerged in Wuhan, Hubei province in December 2019. Kenya reported its beginning of COVID-19 in March 2020 and has been increasing across the country, with the initial cases beginning in Nairobi and Mombasa. Globally, as of December, there have been around 67 million confirmed cases and 1.5 million deaths. Kenya has reported to date 90,000 confirmed cases and 1,500 deaths. Healthcare workers still remain the main personnel involved in screening and the treatment of this condition throughout. Facing this critical situation, healthcare workers involved in the diagnosis, treatment, and care of COVID-19 are at a risk of developing psychological diseases and other mental health symptoms. During the SARS and the MERS epidemic, it was reported that healthcare workers had high levels of stress that resulted in post-traumatic stress disorder. Despite remaining the crisis management personnel, healthcare workers themselves are not immune to the psychological consequences due to COVID-19. And the reasons of adverse outcomes in them range from excessive workload and long work hours, inadequate personal protective equipment, over-enthusiastic media news, feeling inadequately supported, and the need to make difficult ethically and morally decisions, and the lack of social support, and the fear of isolating and infecting family members. There has been a lot of literature that has been published from the various parts of the world that have reported higher risk of developing mental health disorders. Lai et al. Reported with a study done in China that from around 34% to 71% of healthcare workers reported symptoms of depression, anxiety, insomnia, and distress. Papa et al. In a systematic review stated that 1 in 5 healthcare workers reported symptoms of depression and anxiety. Rossi et al., a study done in Italy, reported that younger age and female sex was associated with post-traumatic stress symptoms, depression, anxiety, and perceived stress. Schechter et al., with a study done in New York, reported that around 33% to 57% of healthcare workers reported of acute stress, depression, and anxiety. As you can see, mental health symptoms is a worry, and that all of the studies done across the different parts of the world report the similar results. The well-being of healthcare workers remain crucial for them to fight this pandemic. Mental health in general is underappreciated and further poorly understood and underreported in sub-Saharan Africa. There is lack of insight in the prevalence of mental health disorders in healthcare workers during the COVID-19 pandemic in Kenya and sub-Saharan Africa. Monitoring the healthcare workers' mental health will further allow effective coping strategies into the care of healthcare workers. And therefore, for this study, we wanted to determine the prevalence of mental health disorders and the symptoms among healthcare workers during the COVID-19 pandemic. We further wanted to then compare the mental health disorders and the symptoms among the working position, that is comparing the front line versus the second line. This study was approved by the AKU Ethics and Review Committee, And it was a cross-sectional survey that was conducted between 10th of August and 30th of November 2020. The participants were healthcare providers such as physicians, nurses, residents, and fellows from the Aga Khan University Hospital. The online survey was collected through the RedCap software, and online consent was obtained from all the participants. The participants were referred to a follow-up to the mental health clinics or the internal medicine clinics at the Aga Khan University Hospital if there was a score that had indicated a mental health issue. The questionnaire consisted of demographic and work title characteristics and COVID-19 care information, and the depression through the PHQ-9 questionnaire, anxiety through the GAD-7 questionnaire, insomnia through the ISI questionnaire, distress through the IESR questionnaire, and a burnout through the SPFI questionnaire. Data analysis was done through Fish's exact test for the association analysis using the categorical variables. And furthermore, we deployed a multivariate logistic regression to look at independent risk factors of the mental health disorders. A p-value of less than 0.05 was considered as statistically significant. So here we looked at the overall demographics. So 605 healthcare workers were approached to take part into this survey. We had a response rate of 61.2%, and out of the 370 that had responded, 350 consented to participate in this survey. The median age of the participants was 33.5 years, which is pretty much a younger age population. The majority of the participants were females at 58.3% and were married at 55.6%. 51% were doctors and 66% were frontline healthcare workers. 47.4% had cared about 5 to 20 COVID-19 patients, and 56.1% had lost at least one patient. 66.5% stated having enough resources and protective gear to care, and 61% reported having adequately trained for COVID-19. 3.7% of the participants had a prior history of a mental health disorder. So overall, the prevalence of the mental health disorders for this cohort ranged from 28.6% to 49.7% as seen over there. We then looked at the association between the mental health disorders and the working position. And we found out that depression, insomnia, distress, and burnout were significantly associated with working position, where the frontline healthcare workers had reported higher rates of the mental health disorders. We then went ahead and did a multivariate logistic regression to look at the independent associations between the demographic characteristics with the mental health disorders. And the four tables over there represent for depression, insomnia, distress, and burnout. And you can see that frontline healthcare workers and doctors were more likely to develop depression than the second line workers and the nurses. The frontline healthcare workers, furthermore, were more likely to develop insomnia than the second line workers. The females were more likely to develop distress than the males. And the frontline healthcare workers and the females were more likely to develop burnout than the second line and the males. And you can see that the odds of all of this is from 1.8 to around 4.5, which is a very high odds of developing the mental health disorders. And this model was adjusted for age, gender, marital status, and the healthcare category and the COVID care where appropriate. In summary and in conclusion, this is the first study looking at mental health outcomes among healthcare workers during the COVID-19 pandemic in Kenya. Similar to other studies, healthcare workers at the Aga Khan University Hospital directly involved in COVID-19 care reported higher rates of mental health symptoms. And mitigating strategies specific to the Kenyan healthcare workers are urgently needed to help cope with mental health symptoms during such a pandemic. These are my references, and thank you.
Thank you very much for an excellent presentation. As per the rules of this gathering, we will save our questions until the three speakers have finished. And I believe now we have the second speaker coming from online. Is that correct? This will be Sharon Omenda from the International Center for Reproductive Health in Kenya. And she will talk about HIV service delivery for key populations during this COVID pandemic. Another very important topic as it relates to COVID.
Good evening, everyone, and welcome to another session. My name is Sharon Omenda from the International Center for Reproductive Health in Kenya. And today I will be making a presentation on the impact of GSD on detention and virological suppression of female sex workers because of HIV and COVID-19. So as an organization, we are a local non-governmental organization that is affiliated to other offices in Mozambique and Belgium. And our work falls under 4 main thematic areas, that is HIV and AIDS, reproductive maternal and emerging childhood, family planning, sexual and gender-based violence, and adolescent sexual and reproductive health. So there is a precedence for expediting GSD approaches during the times of an emergency. In the 2014-2015 Ebola outbreak, Guinea started providing persons living with HIV with 6-month ART refills, both to ensure that the patients were not exposed to Ebola and existing health facilities, and because many health facilities were closed. This had a positive impact on the retention of persons living with HIV. Likewise, in the wake of the COVID-19 pandemic, with the initial ban of restriction and persistent containment measures in place, with the aim to reduce physical contact, there persists a need to ensure uninterrupted ART provision and retention of HIV clients. So pre-COVID, NASCOP recommended stable clients to be put on major DSD models in support of the WHO 2016 recommendations. So these models were the community ART groups where persons living with HIV meet at the community and as service provider led, where these gatherings would serve as venues for psychosocial support groups, ART dispensation, and viral load sample collection points. Then the second model was the facility ART groups, where persons living with HIV would meet as a group at the facility versus standalone visits. This was important in reducing workload for the service provider. And here, once again, we have the psychosocial support groups that occur, the ART dispensing, and the viral load sample collection. Then the third one was the fast track model, where clients have 3 monthly encounters with the facility where they would come for refills and alternate clinical consultation. So adaptations of DSD in response to the COVID-19. So post-COVID-19, the models were maintained because they were seen to be result-oriented. However, these models were adapted as follows: that all HIV positive clients, both on-site and off-site, irrespective of stability, were put on a DSD model as recommended by NASCOP. And from March 2020, after the lockdown, we started giving multi-month dispensing in all models instead of monthly. The problem statement was that due to the restrictions of the COVID-19, we foresaw a rise in defaulter rates and a fall in viral suppression of clients due to the containment measures that limited access to the facility and the context of current pressures on the health system posed by the pandemic. So we hypothesized that incorporation of all clients on DSD models and provision of drugs at the community will see equal retention and virological suppression of female sex workers living with HIV on ART. So the main objective of the study, it was aimed at evaluating the impact of differentiated service delivery adaptations on retention and virological suppression of female sex workers living with HIV during COVID-19. So in terms of methodology, it was a study that was a time series analysis of routine program data that was collected, comparing the HIV viral load suppression and retention rates among female sex workers receiving services at ICRHK, supported clinics, which are the drop-in centers on DSD before COVID and during COVID. So the before COVID period was between 1st October 2019 to 31st March 2020, and post-COVID was 1st April to 30th September. So on the DSD segregation, pre-COVIDly, we had 715 clients on DSD and 165 were not. And post-COVIDly, we had 819 on DSD and 146 were not. On our retention cascade, we had 629 clients who were active totally pre-COVIDly, with 179 defaulters and 172 returned to care. And post-COVID, we had 1,128, of which we had 86 defaulters and 79 were managed to be returned to care. On our suppression cascade, we had 629 total active pre-COVIDly, of which 342 had viral load samples done, and 323 were suppressed. That gave us a percentage of 94% suppression. And post-COVIDly, we had 1,128, of which 524 had viral loads done and 498 were suppressed, gave us a suppression percentage of 94%. So in conclusion, from our findings, we have seen an increase in virological suppression from 94% to 97%. There has also been an increase in retention rates, and the model has assisted in defaulter tracing. We disproved our hypothesis that stated that due to the restrictions on COVID-19, there will be a rise in defaulter rates and a fall in virological suppression of clients as a result of the containment measures that were limited, that ensured limited access to the facility and the context of current pressure on the health systems posed by the pandemic. We will continue to use these models in the care of our persons living with HIV, as they have been proven to be result-oriented and sustainable, and NASCOP is currently recommending continuity. Thank you very much.
Thank you very much for an excellent presentation. And also for keeping on time for our speakers, so that's been fantastic. We are now getting ready for the third and final speaker of this session. This is Dr. Matheka Cyrus from Aga Khan University, in fact, from my own department of technology. And he's talking about an evaluation of antigen and antibody lateral flow assays and extraction-free RT-PCR for COVID-19 detection. So as we are ready, go ahead. I will hold up my hand at 9 minutes. The questions will come to all three speakers at the end of his talk.
It's not really, it's not really, not really. Yeah. You can still stop sharing. So stop sharing. Close this. Stop sharing. Now. Stop sharing. You have to open the mouse. presentation.
Good afternoon and good evening, everyone. My name is Dr. Cyrus Matheka. I'm a first-year resident in the Department of Clinical Pathology, pursuing clinical pathology. And what I am presenting today is my study proposal. So I do not have results, but I hope that I'm going to present something exciting for us this evening. So as Dr. Shah said that in December 2019, increasing cases of pneumonia that had not been described before were reported in China. And up to today, we have more than 69 million people who have been affected by this disease. And globally, there are more than 1.5 million deaths today. And most of the global efforts have been led and have been directed towards the containment of this pandemic. And it is important that as we try to contain the pandemic, measures that try to reduce the spread, like what we've seen in many countries, lockdowns and all that. But it is important that early, rapid, and large-scale diagnostics and accurate diagnostic methods are rolled out as a measure towards containing the further spread of the disease. Currently, the PCR method is the gold standard for testing COVID. However, it is not easy to scale up because of the heavy infrastructure that is needed, the specialized human resource, and also the shortage of reagents globally. That makes it challenging to roll out at large scale. The gold standard, according to CDC, is the conventional PCR, which is extraction-based. And in these samples that are obtained usually go through extraction before the amplification on PCR and breeding and then amplification. These methods are preferred because they have high specificity and also sensitivity, which depends on the type of presentation. And because of their complex nature, they are not easy to scale up, especially in low-income countries like ours. The process is labor-intensive and time-consuming, and this usually leads to long turnaround times. If you go to the Aga Khan lab, for example, you find that notice that your COVID results will be ready in 24 to 48 hours. And this calls for us to find other innovative strategies that can reduce the turnaround time, which can be important for infection control, as well as improving casualty workflow management in busy outpatient setups. So methodological simplifications could increase diagnostic availability and efficiency, benefiting both patient care and infection control. And therefore, novel tests that can rapidly be deployed are major priority as we try to contain the spread of this pandemic. So recent attempts have been made at studying what is the use of extraction-free protocols, where, as you can see in this photomicrograph, that the routine testing involves sampling, then the extraction, but there are other novel technologies that once sampling has been done, inactivation can be done of the virus and then transferred to the thermocycler straight without the need for the extraction. And there are also further novel protocols where after sampling, the sample can directly be transferred to the thermocycler, and then after a short time, about 2 hours, we can have a result that can be used for management of the patient. So these novel techniques, which are extraction-free SARS protocol, is what is the basis of our discussion today. Now, rapid diagnostic tests, which include antibodies and antigens, have also been studied. However, they have not shown very good performance initially, and this does not stop us from evaluating them further because they are easy to perform, they have a faster turnaround time, and they could potentially lead to better throughput with less workload. Therefore, it is important to evaluate these tests and see how singly or combined can lead to the rapid diagnosis of COVID infections. If you look at initial data that has been published, we realize that the antigen tests have performed quite well. For example, it's specificity of 100 and sensitivity of 96 for some of the tests. And if you look at the antibody-based kits, the total immunoglobulins, their performance has been shown. Other studies done across many setups, including Uganda, have shown that performance ranges from as low as 10% for sensitivity up to around 99% with good specificity. And therefore, these rapid diagnostic tests can be evaluated and their utility clinically determined. So the research gap that we are trying to look at is in the context of COVID, there is need to validate test methodologies that are easy to perform, that can be scaled up rather rapidly in low-income countries, both in the rural and urban setups where PCR technologies may not be easily available. And therefore, this study will be performed to evaluate the performance of an extraction-free protocol and rapid diagnostic test done singly or in combination. So our research method is what is the diagnostic performance of extraction-free assays and rapid diagnostic tests for the detection of SARS-CoV. And we are going to look as our primary objective at the diagnostic performance of the extraction-free kit. And then our secondary objective will also compare the performance of a prototype SARS plus COVID kit compared to the routine test that we are using in our lab, which is the Altona Real Star COVID test. We'll also then proceed to look at antigen test kit performance and a combined antibody test kit with IgG, IgM cassette. Both these are in vitro diagnostic tools which have either been approved, have received the FDA approval, or they have the CE authorization from Europe. I'll skip the methodology and show this chart how we are going to proceed. So we are going to get patients who are suspected to have COVID, and then we are going to recruit them into the study. If they are more than 18 years, they give a consent, and they are able to give two swabs, two nasopharyngeal swabs, or a nasopharyngeal swab and an oral swab, plus a serum sample for the antibody testing. Then these samples are going to be run on our routine PCR, which is based on Altona kit from Germany. And once we get the results, we're now going to proceed and evaluate the performance of the prototype SARS-CoV plus kit. And the samples that are already known, we are going to subject them now to the RNA extraction-free kit, and then run the antigen test as well, plus the antibody test on the serum samples. And then we are going to evaluate these data subsequently. Our sample size has been calculated using the method proposed by Badner in 1996 to have 228 study participants. And we are going to analyze our data to show our sensitivity, specificity, positive predictive value, and negative predictive value. We shall further move ahead to do a sub-analysis looking at the detection rate in relation to sex, the number of days from symptom onset, and the CT values obtained from the PCR. Before we commence this study, it is going to be approved by the ethical review board, and all the patients are going to give informed consent. Our budgetary consideration, we hope that we're going to get kits from the vendors for validation study, while the Altona kits that are going to be used are the ones available from the hospital used for routine patient testing. The impact of the study is that we hope that the extraction-free protocols and the rapid tests will become additional tools in COVID testing, and therefore they are going to reduce the turnaround time that is achieved before patients achieve their results. We anticipate a challenge that some patients may not consent to give two samples because of the discomfort. However, we aim to evaluate an oropharyngeal swab, which has been validated for both methods and found to be equally useful like a nasopharyngeal swab. And then we are going to disseminate this study to the academia, research organizations, and policymakers with the hope that these research findings are going to influence policy in COVID testing moving forward. Thank you.
Okay, thank you for another excellent presentation, and thank you for keeping to time. So now we have until 6 o'clock for question and answer time.
One question has come through.
And do the people answering have to come up to the front? So,
One question for Dr.
okay, the first question is for Dr. Shah. And the question is, why was there only one nurse mentioned in the results? Yeah, the question is, why was there only one nurse mentioned in the results?
So what we do is we'll be switching to what's
Oh, in the, yeah.
Okay.
I'm not able to pull the slides. Okay. So the nurses were considered as the reference group when you're doing logistic regression, because we had a categorical variable where one group was the doctors and one group was the nurses. And in that results, it had shown that the doctors were more prone to develop the mental health disorders compared to the other group. And you'll see those even, for example, in second line in males, you have to put one of the groups as a reference group.
Yeah, I'm waiting for the other question that came from the chat box. But why don't you go ahead, Stanley?
Yeah, thank you. So I have a question for Dr. Shah as well. And I think this was a really interesting study you did. And thanks for sharing those results. One of the things that I noticed that you had an initial sample selected of 650 participants, and I would be interested to know how those 650 were selected. But then of those, 350 agreed to participate, and I just wanted to get your ideas about what you think the impact would be on a potential selection bias, and how representative that sample actually is of the total workforce. Thank you.
So we did get the emails for all the residents, doctors, nurses, and the fellows that are part of the Aga Khan University Hospital, which is 605. Out of that, we sent an online surveys to all of them on their email addresses, and there were reminders that were sent out every two to 3 days per week to those participants, and from there we got a response rate of 61%, which was 370, where they had to read the study protocol and either agree to participate or decline to participate. So 370 had clicked the link and had put a yes or a no, out of which 350 had put a yes to participate in the study. So we didn't have particularly selecting batches or the cohorts of the doctors and the nurses. We actually sent out an email to every worker at the hospital.
although in follow-up of that, you could have had a selection bias in that those with more symptoms were more likely to answer the questionnaire. So maybe you can respond to that, because although having over 50% uptake rate for a questionnaire online is very, very good.
So we had targeted a 60% response rate, which is considered as a good rate. But we also, so initially we had only healthcare workers that were taking care of COVID patients, and I think the way the title was, they thought that it was just for the people that were taking care of COVID patients, and we had to at least highlight in the survey that this is for anybody. It doesn't have to be you taking care of COVID, because we wanted to look at the differences of the disorders, whether you're a frontline or a second line.
So she was the chat box. I need to read it or hear it.
So you can have a chat box. Yeah? So you can use the question on this WhatsApp. So the question is you can just use it.
That's fine. Okay, the next questions that I see here is a question for Dr. Mateka. Who will pay for the tests? I thought that was mentioned in the presentation that the company is paying for the tests, except that those are already being done for clinical work. The next question. The rapid tests have already been approved for use in the West. What additional information is the study going to offer that would affect decision making?
So the test kits that are available for the study are going to be given by the vendor, so the patients or the study participants will not bear the cost of the study, and the results that are going to be available to the patients are only the results from the routine PCR that is available at the hospital. In terms of the utility of the rapid test, we would like to see their performance in our setup, because they have not shown to have, they've not been evaluated in our setup extensively. And because we are a low-income country where many patients may not access molecular-based techniques, if we have data that support their performance, then this could be an add-on to the diagnostic work for COVID.
Okay, and then another question while you're up here. Did you do a sample size estimation, or is the project driven by the number of kits? If so, will your sample size be adequate? And of course, adequate for what will be the next question.
So we've done a sample size calculation using the method proposed by Banner in 1996, and that gives us a sample size of about 224, and the kits that we have are slightly more than that. So the numbers of the kit available are not based on what the vendors can provide.
Now, questions for Omenda. First one, why did they restrict age inclusion? And second one, why sex workers? So if you can go ahead and address those, that would be great.
Can I have to unmute herself? To unmute herself. Can I have to unmute?
Hi. Thank you very much for those questions. So on the aspect of the sex workers, so as an organization, we offer services to key populations. That is the female sex workers, men having sex with men, and the transgenders, using a drop-in approach. So at our facilities, we are focused on key populations, and so and we did the study in line with the population that we have. So that's why the sex workers. And I'm sorry, I didn't get the first question.
Let's see, the one was age restriction and the other was about sex workers.
For age restriction, we didn't for our program pre-COVIDly, we were using we had an eligibility criteria, and for the program we have a young key population program and a key population program. So for the key population program, it runs across all our facilities, and so it usually we usually take in KPs, who are the key pops, between 15 years and above, and as long as one is a self-identified sex worker. So post-COVID, we were also still using the same population, but this time around other eligibility factors that were there in order to classify a client as stable were not being considered. And so as long as we were able to, as long as you are PLHIV, that's a key population living with HIV, in our drop-in center, we put you under a DSD model and we follow you. So age is a factor because of entry into the program. Yeah, so 15 years and above.
Okay. Thank you very much. We are at the end of our allotted time, so I'm going to turn this back over to Professor Macharia.
Thank you very much, Professor Adam and the presenters. That was an excellent show. And you agree with me that these early researchers have actually come of age. We are aware that there is a lot of research work going on during this COVID period. Immediately, the first cases were reported in China. We know we started having an outpouring of papers. Initially, very simple studies, most of them descriptive, in the form of case reports and case series. And you can see how complex research work is actually now getting, even at laboratory level. So I think it is an excellent show. And once again, thank you very much for that session, and Professor Adam for very good facilitation. We beg your understanding that we are still on the learning trip on how to deal with this digital platform with conferences like this. But I'm sure a year down the line, will be flowing like a river, like water flows in a river. So we now get to that to the next stage of this symposium, where we get to be addressed by one of the keynote speakers. Like I said at the beginning, we have got two of them. We have one who is who is early in her career or in research journey. Then tomorrow we will have one who is pretty well advanced on that journey. So may I call upon Professor Temmerman, who is the chair, Department of Obs and Gynae, and director of the Center of Excellence in Women and Child Health, to introduce our first keynote speaker, as she knows the speaker better than I do. So most welcome, Professor Temmerman.
Thank you very much, Prof. Macharia, and a very good evening to everyone in this session. It's really a pleasure for me to introduce Dr. Angela Koech, known by most of you, but not everyone. So let me give you a little intro. Dr. Koech she obtained her MB-CHB from the University of Nairobi in 2008. And if you go to her profile, she has a lot. Sorry, my video is not working. I'm taking it from my phone. So she has a lot of recognitions as the best final student of the year, the best dissertation, and so on. In 2015, she had the Masters of Science in Epidemiology from the London School of Hygiene and Tropical Medicine. She also has a diploma in information technology from Strathmore University in Kenya. And she is one of our alumni. She got a Master's of Medicine in Obstetrics and her MMed in OBGYN in 2016. Following her MMed, she joined our department as a research physician scientist. And she, over the years, she has contributed significantly to research and research capacity building. She acquired a grant from the Grand Challenges and the African Academy of Science, and she is a Kenyan co-investigator, actually the local PI of the PRECISE project, a multi-center, multi-country project addressing placental disorders and pregnancy outcome. And she's doing a great job as a research leader based in Kilifi, where the project takes place. Angela has published, presented data at international conferences, and has really impressed colleagues and supervisors locally and internationally with the quality of her work, the dedication, her commitment to research. She is now preparing for her PhD and currently registering at Ghent University, expecting to graduate as a PhD in 2020. She is one of the rising stars in Kenya in research and research capacity building, and I'm very happy to work with her and proud to be her mentor. Angela, the floor is yours.
Thank you very much, Professor Madine Temerman. I am a little disoriented after that introduction, but I'm also honored to work with you. And thank you also for this opportunity from the organizers of this conference. I'm really happy to be able to share what I think is really my story. And my hope today is also to encourage the pre-early career researchers and the ones who are really just starting out as early career researchers. I know from previous conferences that we've had last year, the year before, we almost always have keynote speaker who tells us the do's and the don'ts and how to maneuver our way through our research career. So today I'm choosing to address all the reasons we have for having not started, despite all the advice that we have gotten from the previous sessions that we have attended and from other avenues where we have gathered this. So my target audience will be specific, really, pre-early career researchers who have not started yet or who are just beginning. So the more established researchers, do sit back a little while we have this conversation. I'll be sharing my story, which Professor Madine has shared a bit, and I'll borrow a few snippets from my colleagues who I've met along the way. Unfortunately, I am a doctor and an early career researcher, so a lot of my talk will be in the medical field, based on a bit of what a doctor is, but I'm sure you can share even if your profession is slightly different. So I'll start with various excuses, and I think my first excuse here is I really want to do research, but I don't know what to study. And so you spend plenty of time sitting around and asking yourself, what shall I study? Where is the research idea and where is a beautiful idea? And unfortunately, no matter how long you spend sitting at your desk and thinking, hoping for a research idea, you will not come up with a research idea by sitting there. As you've all had before, you will get your research idea where you work, by talking to people, by interacting with their questions and the problems. And people includes your patients, your community, and your colleagues at the workplace. I think once you get the research idea, because we do get the research idea, the trouble really is what then happens to this research idea after you've gained it. And I think this is the difficult part. We always start down here at the bottom of the pyramid where we have so many ideas, big ones, small ones, new ones and old ones, smart ones, and maybe not so smart ones. Some are important, some not so important. But what happens to them along the way is that only a few of these do rise up the ladder to the level where you can actually develop this into full research proposals. And even after the proposals, very few actually get to the end where they get funding, where you implement it and where you start a project and get it to completion. So just a tip along the way for this is that, oops, my slides are not moving. Give me 1 second. A tip here is that grow that idea. Talk about it. I think sometimes we're afraid that if we talk about it, somebody's going to steal my idea, somebody's going to take it and run with it. But really, if you're down here where you're starting, talk about it, get some feedback, and that's how their idea will grow. Sometimes it doesn't work out, park it, revisit it after a few months, maybe even a few years. Or maybe it's a good idea, but it's not for you. Donate it to somebody else. And at some point also be willing to accept that some ideas are to be discarded, maybe parts of it or all of it. I think the hard part is managing these ideas because they start when they're really many. I want to give you a tip, and this is really going tech. All of us have worked with apps for doing just about everything that we do nowadays, from all kinds of examples. So I want to say, manage your ideas using an app. I'm addressing early career researchers. There's lots of apps nowadays for organizing your team, organizing your project, organizing your goals, organizing your progression towards your goals. I'm just sharing one example here of a project from Trello. Really just shows you in the early phases of your study where you're beginning with a project overview, you have a brainstorm list and you can put 1 million tags on this left end where you have all the ideas and then keep moving an idea across the progression. If it's an idea that you've promoted to research proposal level, move it up the ladder. If it's an idea that is still raw, keep it back. But having it here, an idea is never lost. And when you choose to discard it, you archive it and you can always revisit it. So let me encourage you, don't let your ideas fall by the wayside. Wake up at midnight and note down that idea, even as you capture it in your sleep. But what if that's not the problem? You have the perfect research idea, but no money. So, well, you really just need to ask for the money. Ask for the money from institution, from national funders, from international funders. This in itself is the subject of an entire talk, and I would try not to dwell too much on it. But even if you figured out where the money is and you've gone looking for it, sometimes you still get there and find a call for HIV research, a call for childhood nutrition, a call for maternal health. And this year, like all of us have seen, a call for COVID. And you have a research idea for a surgical technique on management on closure of the abdomen after surgery. And I'm thinking, no one's funding my idea. I guess what you should do really is be patient. Okay, be patient, but I need to pay the bills. You're telling me to just wait, but somehow I need to eat even as I wait. And this is the reality. If this is your scenario, then I will just say, be patient. Okay. Oh, sorry. My slides, my boxes are not displaying the text. So the options are continue being patient and then take one of two options. Find something else to do that will pay your bills even as you wait. Sometimes this something else is your clinical career. Sometimes it's teaching. Sometimes it's administration. But while you're doing this, keep a small foot within research so that you don't lose touch. That small foot may just be one journal club that you attend every now and then. That small foot might just be a colleague who you're constantly chatting with about your research ideas. Or the alternative is you find a research idea that is a research project where you can work as staff, where you're working to deliver work objectives that are not necessarily your ideas, but you can contribute to this other research study while you gain research skills. Most of the lead researchers you see in this room, including myself, started out as research staff, study coordinator, project coordinator, research assistant, research nurse. And while you're doing somebody else's work, then that's when you keep growing your own skills and get to the level where you can be able to do your own idea. But don't stay too long away from research because sometimes it's a bit difficult to get your way back. I'll just share briefly how I paid my bills, so to speak. Just after I finished my MEd, I was quite certain I was not keen on a clinical research career. And I told myself, I need to find a place I can do my research, what I want to do. I have these grand ideas. But the truth is, nobody knew me. Nobody would give me the kind of money I needed. But thankfully, Professor Marlene Timmerman, who was just starting to found the Center of Excellence for Women and Child Health East Africa, AKU, as a founding director, needed someone as a physician scientist to be funded internally by AKU to support the work of setting up the center, to source for funding for research work, to contribute to administration, grant writing, and also to research. As the name of the center suggests, the area of interest was broad, including pediatrics, things I did not feel. I'm an obstetrician, sorry, pediatricians. But this was how I paid my bills. But really, it was so much more than paying my bills. While I was sitting in this office as physician scientist, I gained so many skills. I had never applied for a grant myself before this, and I was able to learn grant writing skills. I was able to learn what institutional support exists and what their roles are. I was able to build relationships. In this picture, you will see my graduating class of MEd, Dr. Kimani, Dr. Mududa, and Professor Timmerman. And from this work position, I have been able to acquire Marlene as my mentor. And she's guided me through the profession, sometimes nudging me, sometimes putting real pressure, where real pressure is saying, Angela, you're going to apply for this grant. Come up with something. And sometimes that's what you need to get you moving. And more importantly, opening the entire world to opportunities. Marlene gets invited to lots of things, has so much to do that she will always say, Angela, you do this, you do this. And you only get this by having a relationship with a mentor, and a mentor who's a research leader. So of course, your next excuse is, I don't know people. And it's a common excuse, then where do I begin? So I'm currently joining this meeting today from Kilifi. So I will share a Swahili proverb. Ngagaa na upwa hali wali mkavu. Translated by myself, not a professional, is he who hangs out by the seaside won't eat plain rice. This really means that while you're hanging out by the beach, the fishermen may give some fish to you, or they might just drop some fish while they're heading to their boats, or you may be taught how to fish. So you just need to be in the right place, literally hang out in the right places with the right people. This could be researchers. This is also other people. This includes politicians, health administrators, people who are not doing research, but people who are managing healthcare, which is where your research questions will come. But you have to be very intentional about this. Why? I know there's introverts among us, and introverts, it's not normal for you, it's not natural for you to easily speak to people, approach them and ask the questions. Please just close the door behind your bedroom and practice. Before any conference you're attending, practice, rehearse, introduce yourself in front of the mirror over and over again until it becomes normal and natural. It might take time, but there's no other way to know people. The other way to know people is really be a part of something. It's very rare that you will find research funding or be able to grow a research idea when you're working in an isolated way on your own. Become a part of an institution. Form one, form a group, a formal group or an informal group. And within it, let your skills be diverse so that together as a group, you're stronger than the individual. Think together, write together. I have a friend who's involved in a project in a program in Eldoret. This is established researchers who came together and have formed a group. And this group has different skills of researchers together. And while they're offering healthcare in a small private institution, they are also collaborating together to do research. So you cannot do this when you're on your own. And FOPRO, please do read about it. This is a new, if I was call it new upcoming research, but has been able to do some research, including research for COVID. So when I was saying think together and write together, I want to tell you briefly about a group I am a part of. This group is the PRECISE network, which Professor Marlene has alluded to in her introduction. And it's a network of researchers, institutions, people who come together with a focus of pregnancy research. In this group, I've been able to be part of smaller groups within the larger group where you have a narrow focus in your research interest. You're also able to do several small sub-studies embedded within the larger research project. You're able to do joint work, joint publications, with each author making a small contribution to the whole. I will give you an example. This is a publication that we published early this year about the protocol for the PRECISE study. And you will notice immediately that the number of authors are, I'm not sure, 20, and there's even more because you'll see here, and the PRECISE network. Every single person listed here contributed a small part to the whole, but the publication counts for everybody. The amount of time spent in doing this was less because everyone was contributing to the whole. This is how you grow your research portfolio, not by aiming to write the paper that you're the Angela Koech author alone, but by doing it as part of groups. But I don't have the research skills that I need to do this. Well, you're right, you do need to have the research skills, but you have to be very intentional and specific about how to get them. Spend money, including your own money, to get it. Spend time. Keep refreshing. Things change. What was gold standard a few years ago, or even a few months ago, see COVID, is changing. So do widen your research training, and as you go up, narrow it and become more specific to what you want to do. I'll give you a few examples of remote learning opportunities because that is what we can do now, and it is expanding thoroughly. The University of Washington, for example, has several courses that they offer through the University of Washington Global Health e-learning platform. Short courses available fully online. They last maybe a few weeks or 2 to 3 months or so. These courses are affordable and you can join them as a group. So you get the group psych to be able to finish these courses. I encourage you, this is just one example. There's lots of opportunities online that you can do to build a research career. Or you can go the full pathway of the master's. This is what I opted to do somewhere in between before my MEd and during my MEd. I got an MSc from the epidemiology from the London School of Hygiene and Tropical Medicine. This was fully distance learning, flexible. You could choose to do it quickly in 2 years, or you could spread it out to 4 years. I took the 4-year option. No visa, no travel costs, no accommodation costs. I was able to continue my primary job and my residency and still be able to get the training on the side. This was not easy, but it was totally worth it. But how do you survive this? Again, do it in a group. We enrolled as a group and would sit exams together and feel like, yes, we're doing this so that you don't fall by the wayside. But I don't have a PhD. That's your next excuse, I think. Well, you don't have to have a PhD. There's lots of funding available nowadays that does not require you to have a PhD. A good example is the Grand Challenges Africa funding, and most of the Grand Challenges calls. You will see that they say, we're looking for innovators in this part of the world with any level of experience, working in any discipline, any institution, colleges, universities, government labs, research institutions, NGOs, nonprofit organizations. Really, anybody can apply for these calls, provided you have the skills needed to address the particular question that you're saying. Also, you can get that PhD while you continue to do. I have a friend, Dr. Edith Kamaru Koba, a psychiatrist in Kenya, who many of you will know. She has recently completed her PhD. She's done this while heading a clinical department in Moi Teaching and Referral Hospital, while having full academic responsibilities and still being a mother. It's possible. But so I've done my work, I've submitted it, and they rejected my paper. I have a short story to tell you. And this is a story of, and I was very early in my research career, and I did a course in BSc Anatomy. And I had 2 research projects, and we were required to come up with publications. And this here is my first publication. And as you can see, it is really no publication. That's because I never got to publish this work. It remains a nice, beautiful black book that's still sitting on my desk somewhere. But my second publication from the same work, thankfully, has a better story. And I was able to publish this very early in my career. I'll tell you why. Dr. Peter Gishangi, who you can see is the lead author of this paper, Dr. Peter Gishangi literally took my hand through the entire process of submitting the protocol, getting feedback from reviewers. Whenever I got feedback from reviewers, I said, oh my goodness, I'm done. And he'd say, we'll resolve this and submit again until the paper got published. You can't do this on your own. But you still want to do your other thing, please go ahead and do your other thing. It's possible to keep teaching, keep training, but you have to do this as a team because it's not possible to have a day that's 200%. Share your responsibilities with other people and build a team so that you can share. But it's too late for me. And I think this one is important, and I will specifically to those who have family responsibilities, mostly the mothers. It's not too late. You have been out of work for 5 years on maternity leave or family commitments, or you've taken a long break from research. There's several calls available right now where you can actually apply even though you've taken a break from your research. I'm giving an example here of career development fellowships from EDCTP. You can apply for this if you're a medical doctor with up to 5 years research experience. This means you can be having 15 years clinical experience, but if your actual research experience is 5 years, that's all that counts for you to be eligible. A few other examples from Welcome, and they say here at the bottom, if you've been away from research for a career break, either maternity, leave, or long-term sick leave, this is considered in your application. So don't feel bad, you can still apply and you'll still be considered. There's even calls specific from the Welcome called Research Career Re-Entry Fellowships. Imagine, specifically for people who are trying to get their hand back in research. The theme of our conference today is enhancing science in the face of a pandemic. And I want to just briefly mention our COVID research experience and the one big lesson that we learned while we were doing our research and when COVID happened. One is that you need to be prepared. Well, I guess no one was prepared for COVID, but we were busy doing what we normally do. This is pregnancy care research on placental disorders. And when several calls come for COVID, most of them required a very short turnaround time, and many of them required you to start the research as soon as possible. That is only possible if you're already doing research. We were able to get funding to do some additional COVID work alongside the work that we are already doing for pregnancy, because we had an existing research team, existing infrastructure, and existing data and samples. So keep doing what you're doing, do it well. Then when opportunities come, let them find you there. Enhancing scientists. This is a call really to research leaders. We can't enhance science in this continent if we're not interested in the scientists who are seated in this room, if I was to call this a room. Research leaders, make room for us at the table. Make room for us in your budgets. Make us study coordinator, make us something in there. Help us write the grants. Listen to our small ideas. And to the early career researchers, let's do this together. There's not enough research in Africa by Africans. So there's no competition, let's do this together. Just in case you still have any other excuses, there's a panel session tomorrow by 3 researchers. I hope they will address any other bad questions that you have, and I hope you'll be able to just start. But really, just do it. Start doing the research. Do some research, do a little, do a lot, but remain uniquely you even as you do the research, because this continent needs you. Thank you very much for listening to me today.
Thank you very much, Dr. Poet and Professor Malin Tomaman for that introduction and the good mentor that you have been to Angela. We take a lot of pride, Angela, on you being one of our graduates from our program, and you have indeed done us proud. You have actually demonstrated that as early researchers, we also have a major contribution to make in the field of science, but with emphasis that one has to be very patient, you have to be passionate about the research, and you also must go for opportunities that come your way. There's indeed life outside the clinical practice, but one has to go looking for it and be focused on what you want. I know the day is moving pretty fast. We are getting to the last part of today's sessions. We have 3 more presentations to go, and then we will come to the end. And to lead us through the last session is Professor Luchas, who will come and introduce the other speakers that facilitate the question and answer session. Stanley is the chair of the Department of Population Health here at Araucana University. I hope he's still alert, because he informs me that he has just a day or so ago sent one of the biggest, the most challenging grants he has ever done in his career in research. Welcome, Stanley.
Yeah, thank you, Professor. That is indeed true. I think I've submitted 150 grant applications, but nothing like the NIH U54 application that was due on Tuesday. A great experience. So even for those who are more experienced, I think there's ongoing learning going on in this field. And first of all, a great thank you to the organizers for inviting me here to moderate the next session on health services. And although Prof. Macharia earlier mentioned that we're still learning how to do these conferences, I think for an international conference, and let's not forget that we have international guests among us, I think we're only like 3-4 minutes behind schedule. And that is quite remarkable. So I think we're doing very good. But let me stay on track and introduce the next speaker. I think we have one who will be here in the lecture room, and then two who will be presenting offsite. So the first presentation is Linda Barasa from Aga Khan University Hospital, and she'll be presenting on the assessment of palliative care needs in a Kenyan intensive care unit using a trigger-based model. Thank you. For 9 minutes and then
okay. I'm Dr. Linda Baraza, my third-year resident in the Department of Medicine. I'm grateful for the opportunity to present at this symposium. I'm presenting today on the assessment of palliative care needs in a Kenyan intensive care unit based on a trigger-based model. Thank you to my supervisors, Prof. Karar, Dr. Shah, and Dr. Weru, who are here in the audience with us today. Patients admitted to the intensive care unit often have many palliative care needs. Some of these needs include fostering better communication, psychosocial support, and in receiving patient-centered care. Palliative care involvement in the management of these patients has been shown to result in better outcomes for these patients. Some of these outcomes include shorter length of ICU stay, faster transition to hospice care, faster transition to do not resuscitate status, and family satisfaction with the care received. Palliative care trigger points are clinical screening criteria used to prompt palliative care consultation, and use of these triggers has been shown to result in better utilization of ICU resources with a cost benefit. The most widely studied and used triggers are ICU admission after hospital stay 10 or more days, age more than 80 with 2 or more life-threatening comorbidities, diagnosis of active stage 4 malignancy, status after cardiac arrest, and diagnosis of intracerebral hemorrhage that requires mechanical ventilation. We performed a search of the literature on use of palliative triggers to prompt palliative consults, and we found a number of studies, some of which include a paper by Norton in 2007, which was a retrospective cohort study that looked at use of the palliative triggers to prompt palliative consults, and they found that this was associated with a shorter length of stay in the ICU. A paper by Hua et al. In 2014 was done across 179 ICUs, and they found that 13.8% of ICU admissions met one or more trigger for palliative consults. In 2017, Zelensky found that receiving a palliative consult in the ICU was associated with positive outcomes such as more frequent do not resuscitate status, faster hospice referrals, shorter length of stay, and direct cost reductions. And finally, in 2018, Makarov performed a quality improvement project where they used palliative triggers to prompt palliative consults, and found that use of the triggers increased palliative consults from 1 in 10 pre-intervention to 1 in 10 pre-intervention to 3 in 10 post-intervention. As you can see, all these papers were done in Western countries, and there have actually been no studies done in Africa on the use of a trigger-based model to guide palliative consults. So we sought to better understand the palliative care needs of patients admitted to the ICU at our institution, and point to the need for a more proactive involvement of the palliative team in the management of these patients, as well as highlight the underutilization of the palliative service for these patients. Our research question: can a palliative care trigger-based model be used to estimate the need for palliative care consults in the intensive care unit? Our primary objective was to estimate the prevalence of ICU admissions who met the criteria for palliative care consults based on the use of the five most commonly used palliative triggers. And our secondary objectives were to determine the association between palliative care consults and the length of ICU stay, time to formal change of goal orders, and ICU mortality. Please note that a formal change of goal order is a legal document that describes the intensity of care that the patient will receive, and it includes the resuscitation status, as well as other aggressive interventions such as hemodialysis, vasopressor support, and parenteral needs. We performed a prospective observational cohort study here at the Aga Khan Hospital ICU between December 2019 and August 2020,
and we included adults aged 18 or more years who met the criteria for admission to the ICU. We sought approval from the IARC at this institution before data collection, and we used the REDCap tool to collect data. Some of the data that we collected included patient demographics, the palliative trigger met, whether the patient received a palliative consult or not, how long they stayed in the ICU, their disposition, whether death or discharge, and the time to a change of goal order. Using this data, we were able to calculate the prevalence of ICU admissions that met the palliative trigger points, and of these, we calculated the proportions of palliative consults that were received. We performed univariate analysis using a Fisher's exact test for the categorical variables and Mann-Whitney test for the continuous variables. We were able to recruit 159 patients, of which 45.3% met at least one trigger point. As you can see on the figure, this figure demonstrates the percentage of ICU patients that met the various triggers, and the two most common triggers of post-cardiac arrest at 15.1% and intracerebral bleed needing mechanical ventilation at 14.5%. In terms of patient demographics, 70.4% of our patients were male with a median age of 57 years, 78.6% were African, and the most common admitting service was internal medicine. This is a table that looks at the demographic characteristics of patients who met the triggers, who met at least one trigger, and we have put it into two groups, the patients who received a palliative consult versus those who did not receive a palliative consult. And as you can see, we had 21 out of 72 patients who met the triggers who received a consult. So 29.2% of the patients who met palliative triggers received a palliative consult. And as you can see, there was no statistically significant difference in terms of the two groups, whether consult or non-consult, in terms of age, gender, ethnicity, functional status, or primary specialty admission. Patients who were in the palliative consult group were more likely to have been admitted from the high dependency unit compared to the non-consult group, and this was statistically significant at 0.03. This is a table that looks again at patients who met at least one or more palliative trigger, and again we have split them into two groups, whether they received a palliative consult or not. And in this table we are looking at their outcomes. So as you can see, the patients in the palliative consult group had higher mortality rates at 76.2%, which was significant with a p-value of 0.04. Patients in the palliative consult group are also more likely to receive a formal change of goals. This was also statistically significant. It's interesting to note that 80.4% of patients who met at least one or more trigger did not receive a formal change of goals, neither did they receive a palliative care consult. At some of the points that we would like to highlight, we found a higher prevalence of ICU patients in our study who met at least one trigger for palliative care consult compared to other studies done in the West, which had prevalences ranging from 13.8 to 26, compared to our study that had a prevalence of 45%. A potential reason for this could be the fact that admission to our ICU is based on an open model, and decision on admission to the ICU is made by the primary physician and not by the ICU consultant. Of the large number of patients who needed palliative care, only 29.2% of these patients got palliative consults. And a potential reason for this could be poor understanding of what palliative care involves, or inaccurate prognostication of the patient by the primary physician. Patients who received palliative consults had higher rates of change of goal orders compared to the non-consult group, and similar findings have been found in Western countries, and this is as a result of better communication with the family. There were 9 patients who received palliative care but did not meet any of the trigger points, and this may show that use of these triggers may need to be adapted to the needs of the specific institution. In summary, this is the first study in Africa that has evaluated the usefulness of palliative care triggers in prompting palliative consult in the ICU, and use of palliative triggers was able to identify a large proportion of patients who need palliative consultation. And we'd like to state that this study has also been accepted for publication. Those are my references. Thank you for your time.
you very much, Dr. Bonanza, for an excellent presentation. We'll keep questions for now until after the three presentations have been completed. I think the next two presentations will both be videos. So the next presentation is from Zoya Lalane from American University. And her presentation is entitled Assessment of Activity Levels and Perceived Barriers for Facilitators to Physical Activity in Pregnancy at Aga Khan University Hospital, Nairobi.
My name is Zoya Lalane, and I'm presenting my dissertation topic on assessment of activity levels and perceived barriers or facilitators to physical activity in pregnancy at Aga Khan University Hospital, Nairobi. In pregnancy, physical inactivity and excessive weight gain can contribute to maternal obesity, preeclampsia, and gestational diabetes. Studies have shown that physical activity in pregnancy has numerous health benefits. A study at Aga Khan University Hospital in 2011 showed that up to 31% of antenatal patients are overweight and 37% are obese. Furthermore, the majority of these women did not engage in formal exercise. The ACOG recommends that pregnant women should perform at least 20 to 30 minutes of moderate intensity exercise on most, if not all, days. This is equivalent to 7.5 metabolic equivalent of task hours per week, a unit to quantify energy expenditure. Findings of studies around the world on the level of physical activity in pregnancy as per the ACOG guideline are inconsistent, but generally below 20% in the antenatal populations. A conceptual framework was used in this study in the form of a socio-ecological model that helps determine behaviors by looking at 5 levels as shown. A strong understanding of physical activity behavior across these levels is needed to inform health promotion and intervention development. The primary objective of the study was to determine physical activity levels in pregnant women. The secondary objective was to explore women's attitudes, barriers, and enabling factors to physical activity in pregnancy. A mixed method cross-sectional study design was used. Pregnant women above the age of 18 in any trimester carrying a single baby with a BMI above 18.5 but less than 40 were included in the study. Any woman with a condition that contraindicated physical activity in pregnancy according to current guidelines was excluded. A socio-demographic tool was used to collect information on each participant. The level of physical activity was gauged using a validated questionnaire from which energy expenditure was calculated. Sample size was determined using a calculation for prevalence, giving a sample of 169 participants. Quantitative data analysis was then performed using SPSS. Descriptive statistics and independent associations were utilized. A subset of women from the broader sample was used to conduct 4 focus group discussions until data saturation. A framework approach was used to analyze data in relation to the socio-ecological model. A total of 233 forms were available for analysis after exclusion. The socio-demographic characteristics showed that the average age and gestation was 31.5 years and 26 weeks pregnant, respectively. The majority of women were married, African, had a university education, and employed. 37.3% of women started pregnancy overweight, with 17.6% obese. 27% of the population performed physical activity at a moderate intensity level. However, only 4% of energy expenditure was in sports or exercise activities. The median energy expenditure on sports or exercise activities was 3.2 met-hours per week, which is well below the ACOG cutoff of 7.5. Only 32% of participants met the ACOG criteria for physical activity in pregnancy. No significant association between women attaining the recommended level of physical activity and the socio-demographic variables was found on chi-squared analysis or further multi-logistic regression analysis. Focus group results were categorized into behavioral beliefs and attitudes, enablers and barriers to physical activity, and possible interventions to increase physical activity participation amongst antenatal patients. In terms of attitudes, participants believed that exercise was important and beneficial, having a positive effect on pregnancy. In terms of behaviors, if an effort was made to engage in physical activity, women felt more comfortable at home rather than at a facility, and instead of engaging in planned exercise, women described physical activity in terms of household or occupational activities. In terms of enabling factors at an intrapersonal level, the most common were perceived benefits of physical activity in pregnancy, of an easier labor and delivery and better weight management. Social support by the partner was perceived as the most powerful interpersonal facilitator. The most common intrapersonal barrier was safety concerns, followed by somatic barriers, including fatigue and pregnancy symptoms. The major interpersonal barrier identified was lack of information from healthcare providers. Possible interventions identified included more information and provision of facility-led programs. The level of physical activity attained as per the ACOG guidelines was 32%, which is higher than other populations. And similar to these populations, most energy expenditure was performed in household or caregiving tasks rather than sports or exercise. This correlates well with the qualitative findings where women preferred to perform exercise at home as part of their daily activity rather than as a planned exercise. 27% of women were moderately active, which is a stark difference from previous studies, which shows over 50% of antenatal women as sedentary. This could be because of the high employment status of the sample population, meaning that women did not have a sedentary lifestyle, but may indicate that women were active because of necessity rather than engaging in planned, moderate intensity activity. This finding correlates well with the qualitative data. In terms of attitudes, women did not regard physical activity as a planned activity, and contrary to previous studies, women did not view pregnancy as a chance to initiate positive lifestyle changes. This shows a clear knowledge gap in the current recommendations. The perception of an easier labor and delivery process is a powerful enabler, and studies have shown that physical activity has been used to prepare for labor and to provide better weight management antenatally and in the postpartum period. Women were generally unaware of physical activity benefits to the baby. As seen in previous studies, safety concerns was a significant barrier. An individual approach rather than a generic approach has been described to overcome this barrier. Lack of information was the most powerful modifiable barrier. Women in this study mentioned that advice from a doctor is taken much more seriously, showing that correct knowledge can facilitate behavior change. Recommendations to increase physical activity in pregnancy to pregnant women include open communication and formation of groups. To healthcare providers includes offering individualized counseling and information on physical activity, enabling partner support, and better use of allied health professionals. To hospital management includes education of healthcare workers on the topic, printed information, and facility-led groups. To the community includes formation of pregnancy-specific groups, to researchers to continue the study with a larger sample size in multiple centers, and finally to policymakers to formulate guidelines to be adopted by other facilities. Thank you.
Thank you very much, Zoya Alani. So we now go straight into the last presentation of the third session, and this is by Hilary Arili on seroprevalence and risk factors for hepatitis B virus infection in adolescent blood donors within selected counties of Western Kenya. This will be another video.
My name is Hilary. I welcome you all to my presentation of my research work called Seroprevalence and Risk Factors of Hepatitis B virus infection in adolescent blood donors within selected countries of Western Kenya. This research was done at a time when the country was facing crisis of blood shortage, and I saw the need to investigate the safety of donor blood, and I felt that could be this was one of the reasons that was causing the blood shortages, though focus was not being put on the possibility of infectious diseases present in blood leading to shortages in the raging debate. Some background information on my research. Hepatitis B virus infection is a worldwide public health challenge, and about 254 million people were chronically infected by hepatitis B as of 2015, with Sub-Saharan African countries bearing the second largest rate of infection after Asia. Now, data on the prevalence of hepatitis B is very important in formulating public health policy control issues. The Kenya National Blood Transfusion Services relies on youthful blood donors aged between 18 and 24 years. And these young adults often engage in risky activities associated with hepatitis B spread, such as risky sexual behaviors, scarification, intravenous drug use, amongst others. Now, notwithstanding the current blood donor safety that have been put in place, hepatitis B still remains hazardous transfusion transmissible infection among donor blood. Hepatitis B is a very highly infectious disease, often with severe and sometimes fatal complications, and very few studies documenting the prevalence and associated risk factors of hepatitis B has been done, especially amongst the high-risk groups such as adolescents. This is also the situation in Kenya. This study sought to determine the prevalence of hepatitis B amongst this key donor population and possibly make recommendations that will improve donor blood safety. This is just something about the objectives that I think I've mentioned in my early presentation. Now, this was a cross-sectional study conducted from the month of April to August in the year of 2019 within the counties of Kisumu, Siaya, and Homa Bay. These three counties form the major blood donor sources in Western Kenya, and they have also recorded some of the highest activities associated with hepatitis B spread, such as risky sexual behaviors, intravenous drug use, amongst others. That is according to the Kenya Demographic Health Survey of 2014. The laboratory procedure was done at the Regional Blood Transfusion Center in Kisumu, and partly it was also done at the National Blood Transfusion Center in Nairobi. Now, the sampling technique was a purposive random sampling. 1,000 adolescent blood donors from 33 different schools, colleges, and universities within the three counties where that had been slotted for a blood donor recruitment exercise drive were targeted as the source of the study participants. Data collection was done using a pre-donation questionnaire that is normally used by the blood transfusion services, and the questionnaire was used to record socio-demographic features as well as the prior risk exposures. The risk factors that the study questionnaire sought included perilous sexual behaviors, scarification of the body, intravenous drug use, and past injuries. To be specific, the questionnaire sought perilous sexual behavior such as if one had a history of receiving money, goods, or favor in exchange of sex, sexual activity with the persons of a known background, or if one had multiple sex partners. Past injuries that were sought included if one had stab wounds or accidental needle stick injuries. And to hide the donor identity for ethical reasons, there was a barcode that was used to link the questionnaire to the blood donor samples. Something briefly about the laboratory procedures. The initial tests to confirm the hepatitis B positivity was done using Murex hepatitis B surface antigen version 3. That is an ELISA-based technique, and all positive samples were shipped to Nairobi for confirmation using the Architect hepatitis B surface antigen qualitative confirmatory assay that uses the chemiluminescent immunoassay technique. Data was analyzed using SPSS version 24. Chi-square test was used to test the statistical significance between the risk factors and the outcome variables at a p-value of 0.05. Logistic regression was used to establish the association between the hepatitis B seroprevalence and risk factors, again at a p-value of 0.05. And then about the results, generally the prevalence of hepatitis B was found to be 3.4. and there was no significant association between the socio-demographic variables such as age, sex, or country of origin with hepatitis B positivity. Now, scarification and high-risk sex behavior turned out to be significantly, the risk factors that were significantly linked to hepatitis B positivity, with risky sexual behavior being the most significant risk factor. As you can see from my graph here, out of the 1,000 participants, 31 reported having had risky sexual behaviors, and amongst these 31, 6 of them turned out to be hepatitis B positive. And then 38 participants reported having had scarification, out of which 5 turned out to be positive for hepatitis B. In conclusion, The significant rate of 3.4 hepatitis B positivity amongst the study participants should be a source of worry, especially for the policy makers such as the Ministry of Health and the Kenya National Blood Transfusion Services. And the significant burden of hepatitis B infection especially among the key donor population should inform reinforcement of hepatitis B control policies, such as the provision of a booster vaccination to groups at continued risk of infection, such as the young adults who are also forming the major blood donor source. The study reports a risky sexual behavior amongst the study reports risky sex behavior as the most significant risk factor, and therefore there's need to foster sex education, especially in colleges and high schools. Then finally, this work has been published in the Biomedical Research International Journal with a link I have provided here so that anyone who is interested in further reading can follow. Otherwise, thank you, and that is the end of my presentation.
Thank you very much, Hilary, for your presentation. And also to you, congratulations for having your research published, as well as Linda, our first speaker in this session. So we now have about 15 minutes for some questions and answers. I think all three speakers are available for questions. And maybe I can kick off myself, and having Linda in the audience here, maybe my question will be directed to her. So I think your study was really interesting, and this trigger-based model seems very valuable. And I just wonder, so how is that going to sort of influence our practice at this at the hospital, or how are you planning to take your findings and inform and spread that information to other policymakers? While we wait for Linda to come, so the email address for questions is posted. So please don't hesitate. Thanks.
Thank you for that question. So I'd like to just state that currently we don't have any guidelines in the ICU on when to involve the palliative care team in the management of this patient. And so we feel that our study has been able to identify that there's a good number of patients that actually require palliative care in their management. We found about 55% of the patients require palliative care. And the first step in getting more involvement of the palliative team into this patient care is by getting that actual number first, and getting people to know that almost half of our patients meet the prevalence, meet the criteria for palliative involvement. So one of the steps in which we could get this to influence patient care is actually by presenting, as we have today at this symposium, and getting the information out there, as well as presenting at the departmental level and at the APR level, and just having the clinicians who are actively involved in the management of these patients know that they do need to have more proactive involvement of the palliative team in the management of their patient.
I have two more questions. Thank you very much. And I have two more questions for you. So one question is, how did you gain consent? And the other one is, did you have any challenges obtaining ethical approval?
So we sought ethical approval from the Institutional Ethics Research Committee, and we did not have any challenges in getting this approval done. We followed the appropriate appropriate steps we submitted to the Ethics Committee, and they responded to us within the appropriate time. In terms of consent, so we sought for exemption from individual consent from the IERC because we did not actually interact with any of the patients. Our data was collected from patients' files, So we did not interact with the patients or with their relatives. So we sought consent directly from the IERC and not from the individual patient.
I think that's it.
Thank you.
Thank you very much for those answers. I then have some questions for Zoya. So if you can maybe unmute yourself. So the question is, what was the rationale for using a BMI up to 40, which is morbidly obese? And then how did you analyze the qualitative data?
Thank you for the questions. I hope you can all hear me. So for the first question, the rationale behind using a BMI below 40 was basically because the questionnaire that I had used, which is the physical pregnancy activity questionnaire, was only validated in that population. So as per the questionnaire guidelines, we had to use that as a cutoff, which actually even worked in our behavior. It worked in our interests, because one of the exclusion criteria as per the ACOG guidelines is they actually have cutoffs where physical activity in pregnancy is contraindicated, and that is if you have a BMI above 40. So it would have anyways been an exclusion if it wasn't already part of the questionnaire that I used. And the second question was, sorry, I think it was, how did I analyze?
How did you analyze the qualitative data?
Sorry, I didn't actually catch the question.
Sorry, so what kind of approach did you take in analyzing the transcripts, the qualitative data?
Oh, okay. So for the transcripts, they were, it was all analyzed using a framework approach. So I actually used the NVivo12 software. And once the focus groups were transcribed, we developed themes and codes according to the socio-ecological model. So in each level of the socio-ecological model, which includes intrapersonal, interpersonal, and environmental factors, we grouped all the barriers and facilitators into these levels, and that's how we created our codes and themes in order to generate the data that we got.
Thank you for that response. And then I have one comment for Zoya as well. The comment is very nice presentation, and I will just give a comment on your study by Alani. I support the findings of this study with regard to interventions to have formal physical activity organized from an institutional level for pregnant women. I believe the Obs-and-Gynae department can work with the nurses and physiotherapists to make physical activity as part of formal ANC follow-up. That was just a comment, no question. Then maybe lastly, one question for Hilary. So looking at your findings, I think you found 3.4% of the population having hepatitis B positive. And one of your conclusions was that sexual behavior was one of the risk factors. And you present the data being that 6 out of 31 reported sexual risk behavior. And so what I would like to sort of know is, what was the proportion of participants who reported sexual risk behaviors among those that were not hepatitis B positive? And was that also close to the 20% or significantly different? Sorry, Henry, if you could please mute yourself. Sorry?
You may need to repeat the question. He says you can't hear the
You can't hear the audio?
so just repeat the question.
So let me repeat my question. So my question is that what you presented, 6 out of 31 participants reported sexual risk behavior. And your conclusion was there that therefore sexual risk behavior is an important correlate. And my question is that what is the proportion of participants who report sexual risk behavior but are hepatitis B negative? So the remaining 970.
Hello, sorry, I completely can't hear you well. I kindly request that if you could type the question, I would really appreciate an answer.
Sorry, we can hear you well. Shall I maybe try one more time?
Pardon?
Maybe without my face mask, you can hear me better.
Yes.
Sorry about that. So my question was that you report that 19% of the participants who were hepatitis B positive showed a sexual risk behavior. And you concluded, I think, from that, saying that the sexual risk behavior is an important factor, a risk factor for hepatitis B. And my question is, out of the remaining 970 participants who were not hepatitis B infected, what was the proportion reporting sexual risk behavior? And was that very different from the 20% in the group who was hepatitis B positive?
Still not getting it clearly, please.
It's okay. So maybe I'm sorry about the quality.
Yeah, I think we can get on a one-on-one. I will be able to answer you properly.
Okay, we can take it maybe offline.
Yes.
So I don't think I have any other.
I'm very sorry for that, please.
Okay, sorry, there's one more question. If you can try this one. So at the beginning of your presentation, you said you intended to establish important safety of blood given to patients. How did you do that? Because in your study, you explained that testing is still being done.
Kindly repeat again, please.
All right, sorry about that, Hilary. I think we leave it at that, and maybe I can send you some of these questions as feedback.
Okay, I like it.
Do you want to do some closing remarks? Okay, please. What do you want me to do? I was going to ask if I could do closing remarks, but please go ahead. Okay. Sorry about that. So I think that finishes the third session of this evening. And so therefore just a few remarks from Prof. Macharia and myself. And I wanted to just take sort of a very brief moment to sort of reflect back on this 2-hour symposium session, which in my opinion was very successful. Given the challenges and the arrangements we are working with, I think we get significant learning out of a symposium like this. So very briefly reflecting. Right. Thank you. So very briefly reflecting on our presentations. So I think we started with Dr. Jasmine Shah presenting that a considerable proportion of our healthcare workers are facing depression. And this is particularly those that are frontline workers and women. And so really highlighting the need for further attention. Then we got a wonderful presentation from Sharon Omenda, who presented on this decentralized service delivery model among female sex workers, showing that viral suppression was still very nice at 94%, both during and after the lockdown of COVID. The third presentation was Dr. Mateka Cyrus, who presented his protocol, a novel diagnostic that really show how well this would work in setting, in a low-income setting like Kenya, using this extraction-free test. After the first 3 presentations, we heard Dr. Angela Koech, a wonderful, insightful presentation, really talking and giving us tips about how to advance a career in research. And I recognized a lot of the problems if I think back of my own sort of startup. But what was very interesting is that her tips and innovative approach was very different from what I had ever thought about. And using an app to tease out your research questions. And I think the 2 key messages that I took away from Angela's presentation was, first of all, perseverance. If you want to do research, just keep at it. And I think the second lesson was called Professor Marlene. I think that was also a clear message. She'll help you out. So then in the third session we just heard, we had 3 presentations. We heard initially Linda discussing the trigger-based model for palliative care, and to really sort of show how this works in our local context. We heard Zoya Lalani discussing the physical activity needs in pregnancy, and that there's really a need for more information, both for healthcare workers and mothers, around this topic. And lastly, the presentation by Hilary on hepatitis B prevalence and some of the factors associated with that. And so I think all in all, a lot of learnings came from a very short 2-hour symposium. If we sort of look back in terms of the research methodologies that all our early career researchers applied, and we heard about cross-sectional studies, we heard about cohorts, mixed method studies, diagnostic accuracy studies. So a lot of different methodologies that are being applied by our early career researchers, and that's certainly commendable. But also in terms of the thematic areas, and there are so many areas that the early career researchers are working and really generating new knowledge, relevant knowledge for our context. So maybe with those few reflections, I would like to stop that. And maybe just to say that tomorrow, of course, 5 p.m. we have another exciting 2.5 hours. It will be a little bit longer, looking at NCDs and diagnostics in more detail. We have a nice keynote address from Prof. Anzala coming up, and then fascinating panel discussions, followed by the awards. Prof. Macharia gave me some notes, and although I don't write very nicely myself, I'm not sure I'm capable. Is there anything I discovered? So then maybe with that, I think we can close this day 1 session of the symposium. Thank you all very much for participating. Thank you also to IT for making this run very smoothly. And then hope to see you all tomorrow evening at 5 p.m. Thank you very much and stay safe. Nobody's clapping. I said nobody's clapping. Not for you. That's good.